Good morning, everyone. My name is Jaesu Han, and I'm a clinical professor here at UC Irvine. I work in the departments of family medicine and in psychiatry. I supervise psychiatry residents in their outpatient psychiatry experience, and then I also work with family physicians over at the Santa Ana FQHC clinic, where I'm a primary care provider there as well as a psychiatric consultant. So over the years, I've certainly worked in both settings and worked with primary care doctors in helping them work with their patients who have depression, anxiety, and other conditions. And I'm excited today to talk to you everyone about anxiety disorders. And hopefully just what you need to know. Although I will say, as I was preparing these slides, it was a bit of a challenge because normally I do this presentation to residents, and so I kind of know where everyone's knowledge base sort of generally is. But of course, if I'm doing this more to the general public, everyone has different levels of understanding about anxiety and anxiety disorders. So hopefully I can sort of navigate just in the right position to be as helpful as I can for as many people as I can. So so I have no disclosures. I have nothing to disclose, I should say. Today, what I'd like to do is talk about anxiety and what makes anxiety an anxiety disorder. And then I'm going to talk about the anxiety disorders, and then finally take some time to explore some management strategies that we have to help people who are really struggling with their anxiety. So the first question, which is always a very interesting one, is, I always pose this to my learners. I say, well, what is anxiety? And, inevitably people sort of say, well, it's when you're nervous. And I say, well, what's being nervous? Well, it's being anxious, and so sometimes it can be a little bit, even though we kind of know what anxiety sort of feels like, it's sometimes difficult to actually describe it, right? And so I'm going to propose that I'm not going to propose, I'm going to tell you that when psychiatrists and mental health professionals hear the word anxiety, what we're kind of assuming that a person's talking about is that there are some mental ruminations or worries about some kind of future threat. And that might be because of something that happened in the past and you're worried about the implications of that, or that's something that's coming up in the future and you're having worries about that. Right? So there is that definite mental component to anxiety, but there's also a very clear physical component to anxiety. And in fact, as I was trying to figure out why my computer wasn't showing the image, I can feel my hands getting a little clammy, right? I could feel some tension in my shoulders as I was thinking about, oh my gosh, I'm going to not get this started like I was hoping I was going to get it started. So there are both the ruminations of I'm going to screw this up, for example, as well as the physical symptoms. And of course, they play on to each other, right? So one sort of accelerates the other. So those are the two components that will vary to some degree depending on what type of anxiety we're talking about. But really, these two components are key. Now, what's very different about anxiety, though, compared to, say, psychosis, right, schizophrenia or mania or major depression, is that we don't say that, oh, that's a healthy amount of psychosis that you have, right? We don't say, oh, that's a healthy amount of mania. But in fact, when we're talking about anxiety, anxiety is normal, right? So that's it. We actually there is a sort of a healthy or adaptive amount of anxiety that we have. And in fact, if I didn't have any anxiety about this talk, I probably wouldn't have prepared for it, right? And I probably would have shown up and not, had the slides right, and everybody would have thought this was a disaster. But because I had some anxiety about this talk coming up, I did prepare, right? So I did do some, modified some slides, created some new slides, because I wanted to make sure that this went successfully. So hopefully, because of that anxiety and that preparation, that's going to lead to a successful presentation. right? And then for other people, it might mean that they're going to study and they may go on to get a degree or to be successful in school or in work or socially. So anxiety is not something that we're trying to eliminate, right? There's a healthy amount of it. It's a matter of making sure that the anxiety doesn't become a problem, right? So when does it become a problem? When does it kind of cross this threshold that psychiatrists will say it is an anxiety disorder? And it really boils down to if that anxiety is provoking so much fear and and worry that is actually out of proportion to the actual threat, and it starts to become maladaptive, right? So instead of helping me be productive, it in fact is interfering with me doing the things that I want to do, that I should be doing, that I have responsibilities to do. So I'm not interacting with friends and family. I'm not going out. I'm not taking advantage of opportunities that present themselves. I'm not doing the things that's going to allow me to, get that promotion, for example. And so it's when this anxiety becomes so overwhelming that it starts to affect our functioning. That's when we start to say, maybe this is not healthy anxiety, but is kind of crossing this threshold of an anxiety disorder. And the other thing to note is that when psychiatrists make the diagnosis of an anxiety disorder, we don't just say, oh, they had some anxiety and it caused a problem this one time, and therefore they have an anxiety disorder. What we should be doing is making sure that this has been going on for some time. And there is this sort of quasi-arbitrary threshold that we say that if this maladaptive anxiety has been going on for 6 or more months, then it's more likely to represent an anxiety disorder. As it turns out, when we see patients in the clinic, most patients will have had this maladaptive anxiety going on for much longer, years before they actually show up to the office and come in for an evaluation. So most people have suffered for a long time, and it's probably because many times people say, well, it's just anxiety, it's not a big deal, I'm sure everybody else has it, and so there can be this delay in coming in for potential management. So the other interesting thing is that when we do see people with an anxiety, or we're concerned about an anxiety disorder, uh, there is, oh, sorry, I see a question here. What is the difference uh, between stress and anxiety? I have learned that stress is normal experience. So stress can be things that happen around us. Uh, Sometimes we call them stressors. And those stressors can be interpreted by our brains in different ways, and it can cause anxiety. And so it's about how we interpret the stress that can determine whether that becomes an anxiety disorder or something that we adapt to, overcome, and move on from. So great question. Okay, so if we do identify someone as having an anxiety disorder, then what we will do is also do a further evaluation just to make sure there isn't something else, right? Because as it turns out, anxiety is often co-occurring. That's what we mean by comorbid. So it's a fancy way of saying it's other things are present as well, or co-occurring conditions. And it turns out if someone does have an anxiety disorder, it's very, very common to have something else as well. And perhaps the most common thing to be there is another anxiety disorder. So for example, if someone has social anxiety disorder, they may also have generalized anxiety disorder. So another anxiety disorder is common. And then major depressive disorder. Major depressive disorder is about 40% of the time you'll see that in a person who has an anxiety disorder. So another anxiety disorder, as I mentioned, a major depression. And then you will also see that they may have other general medical conditions. If that anxiety disorder has been going on for some time, it's not uncommon to see substance use disorders for that occurs over time for that person as well. Yes, I will. There's a question about can I explain the difference between anxiety disorder and panic disorder, and I'm going to definitely do that here in the upcoming slides. So here are the sort of the main, or they are the main anxiety disorders. When I say anxiety disorders, what am I referring to? Here they are. So they are specific phobia, and I'll get into each one of these in a moment. Social anxiety disorder, or SAD, not to be confused with seasonal affective disorder. Generalized anxiety disorder, panic disorder, and agoraphobia. So panic disorder is one of the anxiety disorders, essentially. And you can see here, this is based on a survey of people in the United States back in 2012, that specific phobias actually represent the most common anxiety disorder in the US, followed by social anxiety disorder and the other ones. And interestingly, if you add up all the lifetime prevalences of these anxiety disorders, it shows that anxiety disorders are probably the most common mental health type of mental health condition that people can struggle with. The other thing that's interesting is that females tend to have uh, anxiety disorders more commonly or more frequently than males. And the other interesting note here is that as a general group, anxiety disorders start off when we're younger. So particularly you'll see specific phobia and social anxiety disorder. You'll often see this occurring in late adolescence and when it first begins. Whereas generalized anxiety disorder can occur later and kind of more, it's a little bit more spread out in terms of when it occurs. But I think the general rule here is, or the general thing to remember is that anxiety disorders tend to start when we're younger. And so if we have a person that's older in their 50s, 60s, 70s, and they're describing anxiety, we have to be a bit more careful about automatically just saying, oh, it's an anxiety disorder. We do need to consider what else it could be rather than just automatically going to an anxiety disorder. So let's talk about these specific anxiety disorders briefly. So this is going to be a very abbreviated, okay, but just to kind of give people an idea. So specific phobia is, as you can see, that the key diagnostic criteria is that it's marked fear and anxiety about a specific object or situation. And exposure to this object or situation really brings on this acute activation, right? Stress hormone response of adrenaline that can simulate quite a bit like a panic attack, essentially, which I'll get to a little bit later. So different things can be the trigger. So animals, insects. You can see flying on a plane, getting blood drawn, being in an elevator, and heights. So all of these can cause a lot of this adrenaline reaction where we're sweating, shaking, hearts racing, this sort of thing. The one interesting exception is that for many people who have a blood draw sort of phobia, it can actually take the form of a vasovagal reaction where they pass out, rather than some of the more typical ones you can see with animals and flying and that sort of thing. So these specific phobias, as I mentioned, are probably the most common type of, they're not probably, they are the most common type of anxiety disorder. Fortunately, for most people, these simple phobias are things that don't necessarily affect them all the time. So it's not like, most people fly on airplanes every day. Now, if you were a pilot, that would be a problem, but I would assume most pilots don't become pilots if they have a simple phobia of flying, right? But if you do have a phobia of flying and you fly 3 or 4 times a year, that could be a problem during those times, right? If you have a phobia of dogs, you probably don't own a dog, right? So for many people, they will kind of, work their lives around the specific phobia. And it's when this issue becomes more and more prominent, they have to be around the specific phobia more. That's when they often come in for treatment. And interesting, you can see this graph here. It shows that for females, there tends to be a much larger peak when they're in their late adolescence, early adulthood, and then it tends to really drop quite a bit into their early 20s. But then there's a rise in their 30s, and some speculation is that that's when women are typically having babies, and that maybe this is some sort of evolutionary adaptive response of avoiding certain things that potentially could be harmful. I don't know how true that is, but that's something that I've heard. And then as we're older, we do see these bumps, and it's speculated that that's often follows some traumatic events and loss that people have, and that can stimulate some development of some simple phobias. The second anxiety disorder is social anxiety disorder, and it's just like it sounds. It's marked fear and anxiety about acting in a humiliating or embarrassing way in social situations. So this means that when they're at home with their family, people are generally very calm, they're relaxed, it's really not a problem. But the idea of going out to the store and interacting with someone that they don't know very well can prompt this anxiety response, and it's avoided as much as they can. And you can see here that this exists on a spectrum. So some people they really don't have much social anxiety disorder unless it's in a performance situation, whether it's an instrument or they have to talk in front of others, but that in other situations it's really not there. So that's sort of a milder version of social anxiety disorder. And then you have the actual full social anxiety disorder. And then in some people, this aversion is concern about anxiety, being humiliated or embarrassed is much more pervasive, and and that's when we consider the diagnosis of an avoidant personality disorder, when it's much more pervasive. Generalized anxiety disorder is, again, just like it sounds. It's generalized. It is anxiety that is excessive, difficult to control, and related to a number of different activities or events in multiple contexts nearly every day. Patients who have this will say, I've always been told I'm always like a worrywart, right? I'm always assuming that if something can go wrong, it will go wrong, right? And they experience this on this daily basis, and that leaves them with this constant unsettled feeling that you can see there as, restlessness, fatigue, poor concentration, irritability, muscle tension. So sometimes this is referred to as, we say, free-floating anxiety. So it's just kind of whatever the person's thinking about, that's the sort of the content of the anxiety. This tends to have much of a fluctuating course. In other words, social anxiety is kind of always there, whereas generalized anxiety disorder, sometimes what we'll often find is that when things are more stressful, it really flares up, and when things are less stressful, it tends to be less severe. The other very interesting point about generalized anxiety disorder is that many people, even though they have all these worries, because it's such a pervasive, normal thing for them, they don't even almost recognize that it's anxiety, and they will often have many more physical symptoms. And so what we in clinic find is that a person with generalized anxiety disorder, when we look at their chart and we look at their visits over time, we will find that, the person's here for headache, and they may come in for, abdominal cramping, and then they may come in for fatigue, and then they may come in for numbness in their hands. Because their anxiety is so common that every little symptom can be interpreted as a threat. And so it's very common for us as physicians to see patients with generalized anxiety disorder coming in for physical concerns without necessarily coming in and saying, hey, I think I have generalized anxiety. Okay, and then we have panic disorder, but I'm going to start with panic attacks. So a panic attack, and many people, I think years ago I had a panic attack once. It's basically an abrupt onset of intense fear that peaks within minutes, and you have a number of physical symptoms. And you can see here, it might be, racing thoughts. It could be poor concentration, dizziness. It can be issues with feeling like they can't breathe, heart racing, shaking, shivering. It might be this feeling you have to go to the bathroom. It is these can be very, very understandably very distressing. And many people, when they first experience one of these, can often end up in the emergency room because they're worried that they may be having a heart attack or they may be having a stroke. So this is what a panic attack is. Now, um, just because a person has a panic attack doesn't automatically mean that they have panic disorder. So, for example, I had a panic attack years ago, but I don't have panic disorder, right? So, what makes a panic disorder is when a person experiences recurrent, unexpected panic attacks that seems to kind of come out of the blue, right? And this is the very important part, subsequent to that, there is this persistent concern about having more, worries about the consequences of these panic attacks, and or a change in their behavior. Maybe they start to avoid people, places, situations for fear that they may have another panic attack, right? So it is the behavior that occurs after the panic attack that makes panic disorder, not necessarily the panic attack itself. And in fact, I've seen patients who've had one panic attack 10, 15 years ago, and they've never had another one. But the issue is that they are so scared of having another one that they've changed their life around uh, because of that one panic attack years ago. So the frequency of panic attacks doesn't even necessarily reflect that it's more severe. Right. Now it can, but it doesn't automatically mean that, oh, because a person has a panic attack every other day, that is going to be more severe than someone who has it once a month. Because it really is the behavior really determines that. We find that for many people, the onset of panic attacks is usually followed or before the panic attacks. There's often a very major life stressor that occurred in the previous 6 months. So a divorce, a death in the family, something like this, a loss of a job that they've had for many, many years. That stressor may be increasing like the baseline level of stress hormones in that person's body to the point where a panic attack is more likely to be triggered, right? So not to say that that's always the case, but we find that very, very commonly to be the case that there has been some major stressor in the previous 6 months. This is actually the one anxiety disorder that doesn't need 6 months to make the diagnosis. If a person has been having panic attacks and having these behaviors over for a month or more, we can make this diagnosis. But all the other anxiety disorders require at least a 6-month duration. Okay. All right. And then finally, we have agoraphobia. And agoraphobia, as you can see here, is an intense fear or anxiety or in anticipation or entering two or more situations where a person may feel stuck, unable to escape, or to get help. And examples of this would be public transport, being in open or closed off areas, lines, crowds, or being alone outside the home. And the little picture here is really showing that in most cases, agoraphobia develops from a person who started off having panic disorder. As you can imagine, if you're having these panic attacks, you may start to worry that, well, gee, what if I have a panic attack on the train? What if I have a panic attack when I'm in line? And so it can be a consequence of having panic disorder, and then people become much more and more fearful over time of being out. There is a much smaller group of patients who will develop agoraphobia, without a history of panic disorder and could develop it. So there is this relationship between the two conditions, but for most patients, agoraphobia seems to be a consequence of panic disorder, particularly if it's sort of left unmanaged. Okay, so those are the anxiety disorders. I want to make mention though that just because someone's having anxiety symptoms doesn't mean that, oh, it must be an anxiety disorder. It turns out anxiety, or what's felt as anxiety, can be from other things. And so there are certain medical conditions, for example, that can mimic or simulate an anxiety disorder or the symptoms of anxiety. There are actually medications that we prescribe that also can cause anxious symptoms. So just a partial list here that I have, and one thing I would also want to add is that not everybody who has these conditions have anxiety symptoms. It's just that there are some patients who have these conditions who can also then experience anxiety symptoms. So heart arrhythmias, which can cause your heart to be really racing, for example. If you're having a pulmonary or a lung condition like asthma or COPD, that can simulate an anxiety disorder. You can have hyperthyroidism, which is where the hormone that really makes all of our body systems sort of speed up and cause things like racing heart. Hypoglycemia or low blood sugar from diabetes. For example, someone who's taking insulin who maybe took their insulin without eating and now their sugars really dropped. The body responds by, increasing adrenaline, which then speeds up the heart. Anemia, seizure disorder, and then substance intoxication. So if someone's using methamphetamine, for example, that can simulate anxiety symptoms. If a person's in withdrawal from opioids or alcohol, that can actually cause our autonomic system to be on overdrive and cause things like increased heart rate, etc. Medications can also cause symptoms. So if a person's on a stimulants for, say, attention deficit disorder, if a person's taking pseudoephedrine for, like a cold, beta agonists, these are things like albuterol, for example. Certain medications that we use for Parkinson's, and then oral or injected corticosteroids, things like prednisone. My daughter actually, about a month ago, she had this rash, and so she was prescribed prednisone, and she had this reaction to the prednisone that made her feel very, very edgy and jumpy, and she was feeling very, very anxious from taking the prednisone. So bottom line is that there are some medical conditions that can also simulate symptoms of anxiety. So the question was, is it only hyperthyroidism that causes similar symptoms, or is it hypothyroidism as well? It's usually associated with hyperthyroidism, although, interestingly, as people get older, and if they have hypothyroidism, they can actually get, any kind of thyroid dysfunction. People can kind of get this mixed picture. So yeah, you can have symptoms of anxiety with hypothyroidism, but it's typically associated with hyperthyroidism. Okay, so those are some medical factors that can also lead to anxiety. But I also want to highlight that anxiety, there are even a broader set of factors that lead to anxiety. So we talked about some of the genetic, or the family history of anxiety, because many of these anxiety disorders run in families. There is a history of childhood trauma, or what we call adverse childhood events, or ACEs. This can predispose people more to having an anxiety disorder. But and then we also mentioned, I already mentioned the medical issues that can also lead to contribute. But on top of those things, there are other factors like health habits, diet, sleep, excessive caffeine and alcohol use, lack of exercise, and then issues at work and issues in our relationships. All these are factors that can drive and increase our risk of developing an anxiety disorder. And a lot of this can be because of this increase in our stress hormones, cortisol, adrenaline. They can really kind of lead us to have more physical symptoms of anxiety. And when that happens, we have these very anxious thoughts about what's going on with my body, right? Why am I having this racing heart rate? All of these things lead us to have an anxious mood, right? And the issue with that is that those thoughts, physical sensations, and the moods then lead to these maladaptive behaviors, where we may start to avoid places and situations that seem to trigger our anxiety. we may start to isolate ourselves, and we may look to other substances for that temporary relief. If we look at the bottom part here about the anxious thoughts and the behavior, we can also consider it in a different form of this anxiety cycle, right? So you can see at the top here it says trigger, and that trigger could be a lot of different things. So for example, a person with generalized anxiety disorder thinking about getting onto the freeway, and they may think, if I get on the freeway, I will get into an accident, right? Or if a person is having panic attacks and they think to themselves, if I feel palpitations, it means I'm having a panic attack. Or finally, if someone has social anxiety disorder, and they may think, if I say something, I'm going to sound dumb, right? And if a person believes those thoughts, right, and we call these underlying assumptions, if they believe these assumptions, that's going to, not surprisingly, lead to this anxious mood, right, of fear or terror. And what naturally happens is if we think these things, our body responds by releasing even more stress hormones, which then leads to racing heart, sweating, nausea, chest tightness, and then we think, oh my God, I really am having a heart attack, right? So this leaves a person very much feeling out of control. So what does a person do? Well, it's not so surprising that they may start to avoid places and situations. They may do safety behaviors, such as I only go to the store if I have my partner with me, as an example, right? And all of this then reinforces this cycle. So if we think about this as what's driving a lot of the anxiety that a person experiences, we may ask, well, how do providers help people who are having these issues? And there are two broad sets of things that we offer our patients. There's talk therapy and there's medications, right? So if we look at, well, where does talk therapy work on this cycle? We find that talk therapy works at the level of working on these thoughts, right, that people are having, and trying to help people who are having these underlying assumptions and trying to change those underlying assumptions. And if they start to experience physical symptoms, we help people rethink how they're interpreting those physical symptoms, right? If we think about, well, where does medication intervene in this cycle? Medications generally intervene not so much in the thoughts directly, but they really work at the level of the physical symptoms. They help to blunt some of that physical activation that people experience, and the idea is that will then secondarily reduce those anxious thoughts, right? So those are the ways, sort of the general, it's a simplified picture, but that's the sort of a general way that the treatments help people with anxiety. So what is our approach? Well, when I see a person coming in for anxiety, first thing that I do is I try to explore those factors that are leading to the anxiety, and I try to collaborate with them on the health habits and talking to them about stress reduction. So these are the factors that I was mentioning earlier about health habits and stressors. What are some things that we can do at that level before we talk about medications and talk therapy per se, right? Because some people will be able to recognize that, gee, you know what? I really have, my diet really has been bad, and my sleep cycle has been really all over the place, and I really haven't been exercising. And sometimes we might just start at that level without even going into more formal treatment, right? We may take a look at their medical issues and see, well, where can we make some changes or adjustments there, or what are some things in work that we might be able to work on to reduce some of the stress that they're having. So once we do that, and let's say that we've tried to address those things, but the person is still having issues, that's when we start to think about medications and we start to talk about talk therapy. So when it comes to medication, as I'll get into in a moment, there are particular types of antidepressants that help people. There are some additional medications that we use in selected cases. And then in terms of talk therapy, cognitive behavioral therapy is probably the most evidence-based and consistently shown to be effective for anxiety disorders. And if we look here at this table, it just sort of summarizes some of the treatments that we do have. And what's notable here is that for, PD is panic disorder, GAD is generalized anxiety disorder, SAD is social anxiety disorder, and SP is specific phobia. You can see that the SSRIs, which are the medications, the serotonin medications, and cognitive behavioral therapy, they are effective for the three major anxiety disorders, right? It's cognitive behavioral therapy. It's also effective for specific phobias, and it's considered sort of the gold standard for specific phobias. And in fact, we don't usually prescribe medications at all for specific phobias. But the main take-home point here is that SSRIs and cognitive behavioral therapy are both effective for all the major anxiety disorders. So what is cognitive behavioral therapy? So cognitive behavioral therapy is a form of talk therapy that explores, that really focuses on that anxiety cycle I was mentioning a few slides ago. And the goal of cognitive behavioral therapy is to help a person approach anxiety instead of running away from it, right? Help manage that anxiety. And the goal really isn't not eliminating it or avoiding anxiety, right? Because as I mentioned before, anxiety, it can be healthy, right? So we don't want to turn off the fire alarm because it's going off. We want to, calibrate when that fire alarm is going off, right? So we talk about that at the beginning. We also work with our patients about certain strategies that help them relax. So deep breathing techniques, progressive muscle relaxation techniques. Those are some skills that we work on with patients. And then the core pieces of cognitive behavioral therapy is helping them recognize what their underlying assumptions are, right? To help them understand that their behavior is not driven by random thoughts, but that there's these assumptions that are kind of at play under the surface. And in certain situations, we work with them to develop action plans and how to change what's going on in their lives to reduce their anxiety. But the other core piece is we help them to gradually test the anxiety, develop experiments to test anxiety provoking situations and help them develop new, more adaptive underlying assumptions. So here, as I showed you before, we have these automatic assumptions. We actually help them develop behavioral experiments to see if the outcome that they're always expecting actually occurs, right? Because as we know, most of the time, the vast majority of the time, the thing that they think is going to happen doesn't actually happen. But just telling them that is not effective. It's actually setting up specific experiments to test it, right? The other thing that we do is that we even, sometimes things do happen, right? If maybe the person gets on the freeway and they get into a fender bender, right? What if the person does say something and someone does kind of make a negative comment? Well, then we help them develop ways of coping when those things do occur, right? Because if we think about anxiety, it's about the worry about something that's going to happen and then also worry that they wouldn't be able to cope with it if and when it did. So if we address both sides of that equation, the person has much more confidence in their ability to pull through and lowers that overall level of anxiety. So that's how we work with our patients with CBT. There's obviously much more to this, but this is a very simplified, hopefully clear explanation of just with a general overall approach. The other thing to just keep in mind is that when I say cognitive behavioral therapy, it's talk therapy, but it's not, it's not like years of therapy, right? We're talking about 10 to 20 weekly sessions. And while there may be some initial increase in anxiety at the very beginning, by the third or fourth week, people generally start to feel better because we're helping them actually take more control of the anxiety and really get them more excited about testing rather than running away and avoiding. A quick note about medications here. There are lots of meds. Psychiatrists have a whole bunch of meds at their disposal to prescribe. We try our best to hold off on these medications, or certainly I do, until patients have more sort of moderate to severe anxiety disorders. Really try to focus on the other elements I just mentioned for the mild to moderate anxiety disorders. The key antidepressants that are used, or the first line ones, are the SSRIs, are the ones at the top, the citalopram, escitalopram, sertraline, fluoxetine, paroxetine. There are these other ones, venlafaxine and duloxetine, that are also effective. They tend to have a little bit more side effects than the SSRIs, but some people who have issues with nerve pain, for example, might benefit from taking the venlafaxine or duloxetine because it works for those as well. There is this buspirone that's used for generalized anxiety disorder specifically, but it's not as frequently used as the antidepressants I just mentioned. There are these benzodiazepines, alprazolam, lorazepam, diazepam, and basically the PAM drugs. They are considered really second-line options for medications because they can cause cognitive or thinking problems, balance problems. They can be quite sedating in some patients. There is a risk of dependency and respiratory depression, especially when taken with opioids or painkillers. So we really try to not use these medications as much as we can. Sometimes we have to, but they're not considered the first line drugs. And I will make a quick note about some commonly used off-label drugs. So these drugs are not FDA approved for anxiety disorders, but you will see them prescribed, typically for sort of like as needed use. So hydroxyzine, which is the trade name for that is Vistaril. It's an antihistamine, kind of like Benadryl, but it doesn't. The side effect is a little bit better than Benadryl, and it doesn't cause as much problems with like confusions, etc. So sometimes you'll see that used for generalized anxiety disorder. There's propranolol, which is a blood pressure medication that we use in low doses for performance anxiety in particular. And then you will see medications like gabapentin used for anxiety. It's not FDA approved for any of the anxiety disorders, but you will see some providers prescribe that. And then pregabalin, which is very similar to gabapentin, is actually approved in England for use with generalized anxiety disorder. So between pregabalin and gabapentin, pregabalin has better evidence for use in anxiety disorders. And then finally, I will make a shout out to the nutraceuticals here, which these are like inositol, L-theanine. These are sort of amino acid derivatives, which have been shown to have some benefit for anxiety. And there's even some botanicals like lavender, which have shown some benefit for anxiety. And the other added advantage is that they tend to have fewer side effects than the medications I was just mentioning. The downside is that we don't have as much evidence, like good studies to show exactly when, where, which exact situations these can be useful. I'm going to leave it to a speaker in a future talk to kind of get into more of these options, but they are also things that can be tried as well. So last slide here is just, when do you take a medication versus therapy? And really, there's a lot of factors involved. Most definitely patient preference and readiness, right? Some patients just prefer one or the other. They may want to try to avoid medication. Maybe that's all they want is medication. So we really try to individualize that. As far as therapy is concerned, if there isn't a therapist available, it's going to be really hard to do. So the nice thing is that now a lot of therapists do this through Zoom, so that's made that a little bit easier. It may also, another factor is maybe a patient's tried several medications and they really had a lot of side effects. Maybe we ought to avoid medications. And then certainly if a patient has, say, for example, fibromyalgia, and we know that duloxetine, for example, also works for fibromyalgia, we may find that a particular medication can do two things, and two things in one. And then finally, it may be that for the mild to moderate anxiety disorder, we try to stop, we hold off on medications unless we really need it when the anxiety disorder is more severe. So these are some factors that psychiatrists will consider when thinking about what to recommend for our patients. So with that, sorry if I'm just a few minutes behind, but here's my takeaway points here. Anxiety is not always bad. There's a spectrum from healthy to maladaptive and disabling, and we really need to understand where that is for any particular person. That the best outcome that we know that we can get is when we consider all and address all these factors in individualized management. And then if we do need to treat the standard treatments of the medications like the SSRIs and cognitive behavioral therapy are actually equally effective and so reasonable for patients. They don't have to start with medications right away. They can start with therapy and be confident that that can be as effective. So with that, I will stop for questions or wait till the question and answer.
Thanks, Dr. Han. We're going to save your questions for the Ask the Experts right after our intro to mindfulness.